Sorry about that, but finally, sorry about that. Thank you, Alex, and thanks everybody for having me here. It was an interesting question, and I'm glad to see that there's a range of responses. A lot of people, not so many perhaps here today, but they find death and dying something difficult to think about or to talk about. Obviously, that's not the case with me. I've been interested in death and dying for many, many years. I don't generally have much of a concern talking about it in any format. As Alex mentioned, I coordinate the PALS Death Cafes, and you're all welcome to join those anytime. We'll get information to anybody who's interested. But Death Cafes, basically people talk about whatever's on their mind dealing with death or dying, and it's a group-led discussion. And sometimes people bring up about how HIV and AIDS was back in the early days. And, you know, I remember that, and it breaks my heart thinking of how horrible some people had to be alone at their final moments. And I think that's going through that with some of my own friends. I think that's part of who I am today and why I care so much about this topic. But fortunately, things have changed, not just some remarkable medical advances, but also because of groups like PALS and like Let's Kick Ass, who understand or promote, you know, advocacy and self-care. So my supposition is that living with HIV or AIDS kind of mandates fostering a self-care attitude and an advocacy for yourself and for those around you. And my premise is that those same attributes, the self-care and advocacy, should carry through to one's death as well. But key to advocacy, I think, is information and knowledge. That's what I'm hoping today, is just to explain some choices for dying well, so that perhaps it'll give you some food for thought for, you know, things for you to think about, maybe to put in planning directives or other legal documents, or just how you might want to coordinate ahead of time issues that may come up. So I'll be using some terms. I'll try to describe them as I go along, but if you're confused about anything, by all means, let me know. And I do want to caveat that these terms are pretty specific to the United States. Lots of countries have some of these same kinds of options and choices, but the terminology can vary, and what things mean here might mean something else differently. So I'm focusing mostly on the terminology in the United States, particularly in California. So with that, we'll start with a basic definition, and that's, what do I mean by end of life? You know, it's a term that a lot of people use. There is no standard definition, but people banner it about. For today's purposes, it's just that period of time before one's death, when it's pretty likely and pretty known that you're probably going to die from an illness or condition. I'm not putting a specific time frame on it. Some definitions do, but they vary from minutes to months, so they're kind of worthless, at least for today. Here's a couple scenarios that are listed there. I'm sure you can think of a lot more, but ways in which somebody is facing their end of their life. You know, it could be hospitalization after some kind of event, or you could be deteriorating in a nursing home. You could have the same issue presenting itself over and over. Or there's two ways to die. One, a traffic accident is an example of one of them. You die really fast and unexpectedly. Or the other is you die more slowly, and progressively over time you deteriorate. But regardless of whatever type of end of life, you know, these scenarios or these circumstances are always filled with a lot of emotions. I'm sure you have experienced them in your past with loved ones who have died. You know, fear and anger, often guilt, you know, deniability, and the what ifs kick in. I can't really say that talking about and planning for these kinds of things can get rid of all those kind of stressful emotions, but it might help mitigate some of them. I think too, one point I want to make is that I think that our society tends to look at death as a medical event. And really, death is more of a social and an emotional and perhaps a spiritual event than just a medical event. And it's kind of a way I think we can reframe how we look at the whole notion and whole concept of death. And I think this emphasis on the medical aspects of death leads to what I call a default death. And here's a visual of what I mean. This is, I'm sure this scene looks kind of familiar to you. Actually, it's an emergency room scene, but not that different from a hospital room itself. But I'm sure you've probably have experienced this for yourself in the past or for others. And this typifies, the medical model that is underscores our health system here in the United States, where the whole thrust is to fight disease at all costs, to cure, and that can be absolutely essential to sustaining and saving life. I'm not knocking it. I mean, it's great, but it's not necessarily a great way to die. Death in a hospital isn't like in the movies where somebody's surrounded by all their loved ones and they're, talking about how much they love each other and that sort of thing. It doesn't really, generally it doesn't happen that way in a hospital setting. The medical model doesn't really account for how people die. Physicians typically aren't trained in death and dying. They might have one unit at the most on those topics, because again, the medical model is concentrated on curing and eliminating disease. So in some ways, it's up to us to look at, as we're going through different treatments or throughout the course of our lifetime, and look and see, do we feel like we're getting what we need, or is it worth the cost to us? Consider other options that we might want to look at so that we can live our best possible life and not maybe have just life, devolve to the point where your heart's beating or you're breathing. Now, I want to say this default death is actually an option for some people. This is what they would want. Most people in survey, they'll say they want to die at home with no extraordinary measures taken. But other people say they want any and every option to prolong their life. And there's nothing wrong with either of those perspectives. Everybody draws their own line in the sand as to when and under what circumstances life's worth living. And I can't judge anybody else's. I can just know what it is that I want and hope that I know what I want. So if this is the first step, what we're going to talk about, and this is fine if this is what people want, but there are other choices. So that's what we're going to talk about today. And some of them overlap. They're not necessarily mutually exclusive, and there's no right or wrong. But there's a couple constructs I want to go into real briefly first, because this kind of underscores the rest of today's conversation. The first is capacity. When I'm talking about these issues, I'm talking about someone having the capacity to make decisions, to process information so that they can make informed decisions about their own care in line with their own beliefs and values. I also want to talk about agency. This is really a key thing to me. And by agency, I mean self-determination. You get to decide. It's your life, it's your priorities, and it's also your death. So agency is that you have the right to make decisions. And you'll also hear me refer a few times to talking with others and planning, because I think that's fundamental to these issues. So the first thing is in our, I guess, your very first best Nancy Reagan impersonation, you can just say no, because again, assuming you have the capacity, you can refuse any and all medical treatments if you don't want something to continue. Now, treatment is great. I'm not knocking it. I mean, obviously, a lot of us are here, due to the modern medical marvels of medications and all kinds of things. And treatment's great for chronic conditions and manageable diseases. But like it says there, life-sustaining doesn't always equate to life-enhancing. Sometimes treatment can lead to a prolonged dying process and increased suffering without necessarily improving the quality of life. So remember I said capacity. The second and third bullets there, and some studies have found that in adults that were over 60 in the final days of their life, a lot of them were found by clinicians to have impaired capacity, which means the clinician felt they couldn't make their own decision. But yet when the clinician and the patient's relatives conferred about that issue, there was only modest agreement. The relatives didn't feel the same way that the physicians did. So I think that kind of highlights why I think it's important to have tough discussions with your loved ones as well as with your physician. He or she should be part of your planning process. And then document your wishes in an advance directive, and designate somebody who will advocate for you if you're not able to advocate for yourself. Now, as far as treatments, it's not an all or nothing kind of thing. You know, you can say, I want this, I don't want that. And again, you have the agency. You can change your mind anytime. You can revoke anything that you've said and add to it or whatever. The typical or the most common kinds of examples of refusing treatment, most people have heard the bracelet on the left is an example of DNR, do not resuscitate. If somebody has determined for whatever reason they don't want CPR done, they can have a DNR issue, do not resuscitate order. Another common one is hold up if I can get it in front. It's called the pulse. Oops, it's generally on bright pink paper, which I hope is showing up, and maybe it is and isn't. But anyway, that stands for physician order for life-sustaining treatment. And that anybody with a serious medical condition should probably have a pulse. It's something you should talk to your doctor and see if he or she agrees with you. It is a legal document that the patient and the doctor both sign. And it stipulates limits of treatment that you do or do not want. The reason a pulse is important is if someone calls 911, the first responders are trained to look immediately inside the front door and on the outside of the refrigerator. And if there's a pulse listed there, it gives them a guideline of specific things that they should or should not do. That's two type of documents. Another is when I talk about advanced healthcare directives, I'm talking primarily in this case about it's basically a medical proxy for healthcare. People used to call it a living will, and it's actually it actually is sometimes still called that in some contexts. But what the advanced healthcare directive does, it allows you to name an agent is the term that you use, but it's somebody who can make decisions on your behalf, what it is that you have already discussed or that they know from knowing you well, what it is that you want. They can advocate for you to make sure that you get the treatment or not get the treatment if they are unable to make their, if you're unable to make your own assessment or communicate effectively. So when I talk about the advanced directives, at this point, those are the things that are most important. So again, I'm not advocating that everybody stop all treatment, but it's just something to look at over time. And is it having the effect that you want? Bring it up with your physician. Is it something that could be postponed or declined if it's something new? There may be resistance from your physician because, again, they're steeped in the medical model. They're taught to cure. They're not taught to help you die. But at some point, you might have to inquire whether palliative care or hospice would be appropriate. So people often confuse the terms palliative care and hospice. They have an awful lot in common, to be honest. Both palliative care and hospice, and something I'll mention later, end-of-life doula, they all fall under the rubric of comfort care. So the focus is more on quality of life, symptoms management, and it's the things here in the middle. Reducing stress, it treats the family as a unit. It's addressing psychosocial, emotional kinds of issues as well. Some people mistakenly think that palliative care is a step, and once you're through palliative care, then you go into hospice. That's not really the case. It's more hospice is a subset of palliative care. But the important things are what differentiate them. Palliative care is appropriate for serious illnesses like obstructive lung disease, advanced liver cancer, heart attacks. I mean, advanced heart disease, not just a regular heart attack necessarily. Things where there's an awful lot of pain that can't be cured or can't be relieved easily. Palliative care is usually paid by the insurance or by someone pays it by themselves. With with hospice services, hospice is basically pretty much completely covered by Medicare or Medicaid. Most insurances also have some kind of insurance. So if you go on hospice, you basically don't have any out-of-pocket costs. Here's a big difference though. Palliative care is for any stage of the disease. That means once you're diagnosed and you're having issues that require palliative care, you can get those as long as you're alongside going with curative treatments. With hospice, your prognosis has to be 6 months or less. Doesn't mean that at 6 months they kick you off, but your what if diagnosis is if this disease progresses the way I expect to, the prognosis would be 6 months or less. And so entering hospice, you give up all curative treatment. The focus is on specifically the comfort care kinds of issues. You can still get treatment for other medical conditions. You still get treated for the disease, but you're no longer trying to get cured of the disease. That was kind of the third bullet there. And palliative care typically happens in a hospital. And hospice care happens wherever the patient calls home. That could be assisted living, it could be a nursing home, it could be at the patient's home. Before I move on, I want to focus a lot more on hospice, but before I move on, I also want to mention something called palliative sedation, because you may have heard that term or you may hear it. It used to be called terminal sedation or total sedation, but it's a term that's still used, and it's something that's still relatively common. At the end of life, most end-of-life symptoms, most pain and delirium and those kind of things can be treated with meds and sedatives. But sometimes, even with the modern marvels of medicine that we have, sometimes they just are insufficient to relieve intractable suffering. So with palliative sedation, and it has to be done, typically it'll be done in a healthcare facility, because what happens is the physician will inject either subcutaneously or through an IV enough sedatives to make you unconscious. The goal is not to hasten your death, it's to relieve your suffering. So it's not something that hopefully most of us will go through. I always think of being a burn victim. You know, if I'm burned over most of my body, knock me out. You don't need to kill me if you don't want to, but knock me out. I don't want to have to feel the pain of that. And this is considered an appropriate medical practice virtually everywhere. And even Catholic doctors and Catholic hospitals will practice palliative care. But the reason I don't really want to end, I just wanted to mention it so you're aware of it if you hear it. In states where medical aid in dying is legal, such as here in California, typically a terminally ill patient wouldn't have to choose between medical aid and palliative care. But again, I just wanted, in case you hear that term, and not to confuse the two, palliative care and palliative sedation. The reason I want to focus on hospice more so than palliative care is I think hospice is the future for many of us. And the reason I say that is, you know, money talks. So it's who pays. It's that Medicare pays for hospice. And so it's a huge booming business. There were over 40, in 2019, there were over 4,800 medically certified hospices that paid $21 billion for 122 million days of hospice. So in the old days, I was a hospice volunteer back in the 80s. In the old days, most hospices were not for profit. Now the bulk, over 70%, are for profit. That's not necessarily a bad thing. I'm not knocking for-profit hospices, but it sort of has changed the dynamic somewhat in hospices. And with Medicare being so involved now, there's so much more administrative oversight and so much more paperwork that, again, it's changed the nature, forcing hospice somewhat to focus more on the medical aspects than some of the spiritual and emotional and supportive things. And I believe, I could be wrong, but I think most, if not all, the hospices in the Valley are for profit. But so just to dive into hospice a little bit, because like I said, I think it's going to be the future for a lot of us, or for those we care for. Again, the prognosis is for 6 months, and that's like I said, if the disease takes a course. After 6 months, they don't say, oh, you can't be on hospice anymore. They can recertify you. I've known of people on hospice for up to 2.5 years. Obviously, you have to live in the service area that the hospice does. You have to forego the medical interventions, as I mentioned. And again, the agency here, you can stop hospice services and reinstate them at any time. If you have a new curative kind of thing that you would like to try, you can say, hey, I want to go back to my regular healthcare, get out of hospice. I want to try this. You can always come back to hospice, and you can change hospices if you don't like the one that you have. The range of services, it pretty much covers the gamut. Over the little circles there show the types of people who provides hospice support to both the patient and the family. You know, as physicians, you'll get at least one nurse visit a week. As your condition deteriorates, that can increase. You get home health aide visits a couple times a week who can help with bathing and that sort of thing. You get all your medications, your supplies, your hospital bed, other kinds of equipment, hot oxygen if you need it. The hospice will train the family members in how to, take care of issues that come up. And hospice is on call 24/7. One misconception is hospice is 24/7, they'll show up. That's not really the case. They're at least on call 24/7. You can get support. You don't necessarily get a person 24/7. And as I mentioned, hospice is covered by both Medicare and Medi-Cal. A couple misconceptions about hospice, kind of went over some of them. It's not really giving up. Some people live longer, studies have shown, by being in hospice because it relieves the family stress, it relieves some of the financial burden. It gives people time more to address unresolved emotional and other kinds of issues. People think it's largely just for people with cancer. That when hospice first kicked off in the United States, that was largely the case, and it's still mostly people with cancer, but there are a lot more people with dementia kinds of issues, Parkinson's, stroke and respiratory issues. So cancer is still the most, but it's not only cancer. And like I said, it's not normally where you go to die, you die wherever your home is. I've talked about this 6 months. The biggest thing here, I talked about, it doesn't cost a lot of money. The biggest thing that I want to go here is this last bullet where it says it has to be brought up by a doctor. I really want you to encourage anybody who you think, yourself later on in life or anybody that you care about, bring it up to the physician and ask the physician if it might be appropriate to consider hospice for somebody. Doctors, again, the medical model, they're steeped in cure. They don't want to refer to hospice. They want to keep trying to cure you. And what happens is they tend to wait till the last couple days or the last 2 weeks and then refer somebody to hospice. Hospice can still provide service, and they do great work even then. But the social and emotional stuff and the having time as a family unit and family, however we define it, you lose out on that if people come in too late in the process. And unfortunately, the median number of days that somebody is on hospice is 18 days. That's only 2.5 weeks. 10% of people are on hospice for 2 days or less. It's really hard. I mean, yes, if people get to perhaps die at home with loved ones and have that final care provided, but 2 days is not long. 25% are 5 days or less, and 50% are 18 days or less. So again, my push here is don't necessarily wait for a doctor to bring it up. So let's move on to something that I think is a topic of interest for many people, and that's medical aid in dying. Okay, what is medical aid in dying? Well, the acronym is MAID. Here in the United States, it's medical aid in dying. In Canada, it's the same acronym, but it's medical assistance in dying. And just one of those little quirks. But their procedures and policies are much more advanced than ours. But at any rate, I'll discuss California. So it's a safe and trusted medical practice in which a terminally ill and they took the terminally ill, they borrowed the time frame from hospice. So it's 6 months. A person with 6 months or less to live can request from a physician medication that they would have to self-ingest, and that's an important factor too that we'll go into to bring about a peaceful death. Couple key things: it's not euthanasia, it's not suicide, it's not physician suicide. Those terms have been used against those who have pushed for medical aid and dying. So if you hear someone referring to it that way, please explain that it's not that. Even specifically in the California law, it says that medical aid and dying is not suicide. It's not euthanasia because the person has to be able to self-ingest. The physician is not going to do anything active, or whoever is preparing the medications, and we'll get into that as well. Life insurance is not affected, and your death certificate doesn't say you died of medical aid and dying. It shows that you died of your underlying condition. A couple key things here. Right now in the United States, 1 in 5 people live in a state or jurisdiction where it's legal. There's 10 states plus the District of Columbia where it's legal. Surprisingly, if you look at how much public support there is for it, even among the different political and conservative movements, 57% of conservatives support it. A lot more Catholics than even Protestants, but they're all in the majority. So, you know, it's a well-desired kind of, it doesn't mean that there isn't moves afoot that would deny it to us, but like other issues, but there is a lot of widespread support. And again, the agency, if a patient requests this, they may end up not using the meds. Lots of patients don't use the med. Probably a quarter to a third of the people who get the meds end up not using them. It gives them the peace of mind that they could use them if they chose to. So you can withdraw from the process. It's not like once you sign for it that you have to go ahead and do with it. Another key thing, I would recommend that you have hospice involvement. Whether or not the hospice will actually be actively involved, but you kind of want their involvement if you can swing it, and we'll go into that in a little bit as well. So here in California, the act came into effect in 2016. Again, we talked about the things here. You have to be able to medically ingest, have to be a resident of California. Again, the capacity, you have to have the mental capacity to make your own healthcare decisions. You have to self-ingest. That has initially was thought that it would just be oral, but there's some people for a variety of reasons that can't ingest things orally. So you can get it through a feeding tube, through a rectal tube. So there are alternatives. Some important changes went into effect in January of this year. There had been 2 oral requests are required to physicians. There had been a 15-day waiting period between them. What was happening was a lot of people would make a request and die before the 15 days were up. So that has been reduced to, it can be reduced as much as 48 hours. Doctors, it doesn't have to be 48 hours, but if the physician involved feels that time is of the essence, that waiting period between the two can be reduced to 48 hours. Healthcare systems and hospices must post their policies on websites. Well, locally, I'd say, and not just locally, throughout California, most healthcare systems and hospices haven't really posted their policies yet. But individual physicians and healthcare pharmacists, healthcare activities, hospitals, or the like, they can opt out of this. They do not have to participate. And that's an issue we'll get into in a moment. They also did away with a final attestation form, which 2 days before you were going to do it, you had to sign another form. So they got rid of that. And they clarified that made medication can be taken within a healthcare facility. But again, a healthcare facility can say, we won't let anybody do it in our facility. The next to last bullet here, if somebody requests it and the physician doesn't wish to participate, he or she is required to A, tell the patient, I don't wish to participate, B, document in the medical record that they had this conversation, and 3, transfer the patient's record upon request. Those 3 little things there, I'm going to come back to those in a moment. You wouldn't think there would be anything controversial about that. It all sounds pretty cut and dried, but unfortunately, it isn't that easy. So here's some limitations and challenges. Again, the 6-month prognosis. There's some people who, 98, 102, they're nearing the end of their life, but they don't have a 6-month prognosis, but they just feel worn out. They don't qualify under this because being old in and of itself isn't enough of a reason. So that's one issue. Self-ingestion, I mentioned. It gets very hard if somebody has maybe stomach cancer or GI issues to where they can't swallow. Other issues have to be involved, which means other medical people have to be involved. There's nothing saying medical people have to be there for the ingestion, but if you're going to be talking about having things put into an ostomy bag or doing a rectal insertion, you're pretty much dictating that, probably more time and costs with medical people involved. And a biggie is the informed consent, and that comes in primarily because of dementia. I read some shocking stuff the other day about dementia. It said that among the older population, 1 in 2 will die with dementia. It doesn't say they'll die from dementia, but 1 in 2 people will have dementia. I mean, that was pretty incredible to me. And another statistic that I came across was that even people with advanced dementia, because they don't qualify for medical aid in dying, 67%, I believe it was, go to the emergency room at least once in the last month of their lives. So a lot of these people, I'm sure, had they been able to let their wishes known and be able to follow them, wouldn't be in that position. But again, we'll come back to dementia on another topic. But if you have dementia in the United States, you can put in your advance directive that you would wish that nothing happened, or that you could qualify for medical aid in dying, but there's nowhere in the United States where that would be legal at this point, and I don't look for it to change in the very near future. Some other, and I'll try to not dilly-dally here, some other issues is the lack of providers. A lot of physicians practice what's called defensive medicine. They're afraid of litigation. They don't want to do anything that might get them sued or cost them an extra time, with talking with attorneys and that sort of thing. One quick stat, and I got a few more later, but in 2021 in California, 277 physicians prescribed end-of-life medications. Now, I checked, I Googled, and I said, how many physicians are there in California? And it came up to over 75,000 active care physicians. And that was just the MDs, not the DOs. I don't really know what active care per se is, but I'm sure there's probably more. But of even that subset of physicians, 277 is only 0.03 of 1% of physicians in 2001, 5 years after the law went into effect. So finding somebody can be an issue, particularly because of the next bullet, restrictions from employing health systems. A lot of facilities, especially Catholic hospitals, they won't allow any of the people that they have on contract to participate in end of life. That's a real issue with this whole thing. I can tell you a real quick example. Kaiser is very supportive of medical aid in dying. They're allow their physicians to participate. They have palliative care, which supports it. They have hospice, which supports it. They even provide the medications. But in Northern California, this one particular jurisdiction, Kaiser does its palliative care through a Catholic hospital. The Catholic hospital refuses to do it. So even though Kaiser's supportive, there's all these kinds of issues that you may face because of this restriction. Okay, quickly I'll go into costs. Medicare is a federally funded program. They will not provide any end-of-life financial support. There's a couple little workarounds that doctors, in how they code things medically, they may be able to code, maybe a visit where it's discussed, but they will not provide anything else. Medi-Cal, on the other hand, is a state program here in California, and Medi-Cal does support medical aid in dying. Includes well, they don't, I can't say they support everything, but they include the office visits with the physicians. They include the prescriptions. The prescriptions themselves are probably about $700. They're not just prescriptions the doctor can write and go to CVS or Rite Aid or something. They are compounded, and only certain pharmacies do it. So in the timeline, if somebody's considering this, you got to add an extra 7 to 14 days just to get the prescriptions. That's an issue there with the prescriptions. And costs. The physicians, they're not going to do this for free. Some have sliding scales. Here in the desert, I don't know of anybody who is currently writing stuff. I know of somebody from San Diego who covers the desert. His cost is a $4,000 fee, which he says is sliding if somebody can't afford it. That doesn't include the cost of the prescriptions. And if you want him or is more likely a nurse on site, the day of the ingestion, that's an extra $1,500. So, I mean, cost is very definitely an issue with this whole thing. A couple of legal issues that I just wanted to mention as well. Oregon, just some good and some bad. Oregon just judge there ruled against their residency. So now you don't have to be an Oregon resident to pursue medical aid in dying in Oregon. So perhaps that will move it out for others. New Mexico, they just went into effect last year, and they're a little more progressive. They let physicians, assistants, and nurse practitioners write the things as well. Now there's a lot of court challenges. Unfortunately, like I said, it should be easy, but it isn't. One of the challenges that was just settled by a judge here in California was based on an ADA challenge, that saying that people who couldn't swallow were being discriminated against because of their handicap. The judge actually threw that up, even though initially he seemed supportive. Groups are going to try a more narrow focus and take that one back to the courts. But remember those 3 little things that the doctor has to say he meant, or has to document in your medical, tell you that he or she doesn't participate, document it, and then provide your medical record. There's a federal case now filed by the Christian Medical and Dental Association. So that's all I'll say on that. But they filed a case asking for a federal injunction against those provisions, that the doctor has to document that you talk to them about it. My fear is if that federal injunction is granted, it can cause a lot of confusion, and who knows what other federal judges would do. And once federal judges start disagreeing on things, we all know it ends up in the Supreme Court, and who knows what happens with that. But again, a big issue that I wanted to highlight is this can't be used with dementia. A couple of real quick stats in California. I mentioned 772 individuals were prescribed. Only 62% died using the medications. So that's like 38% didn't. Now, some of them may have been towards the end of the year, or they may not have gotten the information. But again, it shows that you don't have to do it if you just do. Population still primarily an older population, 60 or older. The median age was 76. I think the oldest was 102. Mostly split between male and female. Still mostly cancer, but other kinds of things. This is good, useful information anyway. 93% die at home. Even though facilities may let you do it, most people still do it at home. The last one's a little distressing. In California, only 43% had a healthcare professional available. that's kind of dismal. That people are, again, you don't have to have someone there, but the ideal thing would be to have someone there just in case, to help reassure them that things are going correctly and everything else. And what these figures don't take into account is how many people are turned down, how many people say something to their physician and the physician says, I don't do that, or I don't know much about that. And then they end up not being able to pursue what they would rather have had. And then, their priorities are left in the dust. So what if MAID isn't applicable? This is something that isn't quite as well known, I guess, or talked about as medical aid in dying, but this is another option. And this is a legal option for anybody, and anybody with capacity again. So it's voluntary stopping eating and drinking. The acronym is VSED. And it's a conscious act of somebody to stop eating and drinking, and their goal is intentionally to hasten their death. Like I said, it's legal. You have the right to self-determine what happens with you. That's not to say that you're not going to face some kind of resistance. Again, if you're in a Catholic nursing home, good luck. Even regular nursing facilities and assisted livings, not all of them want to be involved with this or to allow someone to do it. And obviously, you're going to have some resistance with loved ones. Some people do. No doctor's orders required, but again, just like with medical aid in dying, I strongly recommend that you not do this alone and that you do have hospice. We can go over a little bit of why. But what it is people say, God, I can't imagine starving to death. And you're not actually starving to death. You're dehydrating, and you're going to die of dehydration rather than starvation. Couple things here. You can just see it's a family affair. You obviously want your family there. It says supported by most hospices. I personally have not been involved with a VSIG case. I know somebody who did it, a former employee of mine, but I haven't been involved with somebody. Again, it's a right. It's a way of ending your suffering. You can kind of choose how you want to go out. You might throw yourself a party a week ahead of time or whatever. But we'll go into how long it takes and that sort of thing. If you have difficulty swallowing, that's some people who don't want to take the meds or can't take the meds, they may choose this route instead. Let me see here. Here's the dying process. And again, this is something that you might want to consider, even if you don't have any signs of dementia. But if you think that, boy, if I had dementia, maybe this is something I would want to consider. And because VSED is something that is feasible to request in that case. Like I said, it varies by individual how long it's going to take. In the first few days, a lot of people report that they're euphoric. They may be a little thirsty. They may, have some kind of discomfort, but a lot of people, I guess the endorphins are going off in their brains and they're actually very happy. That tends to go towards where you start sleeping more and more, longer and longer periods, you get lightheaded. That's why if someone's going to do this, ideally you would have a care network. Doesn't have to be a professional network per se, it could be friends and family, someone to be there around the clock, because you might get confused. Try to get up and walk, and if you're lightheaded, you can fall and cause even more issues. And then the late stage, largely you're unresponsive, and you're basically in a coma-like state. So you're not really feeling any pain at that point. You're just deeply unaware. How long it takes, it's variable. Most people die probably within 10 to 14 days. It depends on several factors, how good your physical condition is. Also, how much do you want this? If you really expect that you want this, I think our brains they tune into us, and you might go even quicker. If you totally avoid the fluids, like even taking little sips of water, that will make the process last longer. And again, depending on your underlying condition. I have a book there, very easy to read, very good book if anybody's interested in this. A woman named Phyllis Schachter, and she has a blog and a website. I mean, her husband chose this approach. She was in his mid-70s, and he had early stage Alzheimer's, and he knew his parents had died of it. He knew what was ahead of him, and they had decided together to do this. She was very supportive, and she documented his process. It took him 9.5 days, and he was able to communicate on some level up until the 8th day. The 8th day, she was saying, you know, are you in any pain? And wink or blink your eyes and stuff, and he was able to do that. So even though some people are largely responsive, some have some level of awareness even longer than that. So I'm not saying this would be a walk in the park for anybody, but it is an option that people would have. Again, probably nothing you want to consider now, but maybe something to think about for the future. If you do develop dementia, you may want to think about it, or if other things just deteriorate to the point where you decide this would be an option, you might want to continue. It honors your free will, it honors your agency, your ability to make your own decisions, to have quality of life and dignity of death. And in my view, in some ways, it takes courage to do this. But the next thing I want to talk about briefly is end-of-life doula. An end-of-life doula is a non-medically trained person who provides holistic support to the family, and that includes practical support. It includes, you know, social support, respite support. The types of services there. It's all of those kinds of things, and any of these options that we talked about. An end-of-life doula may be useful to you, maybe someone who could help you in these kinds of things. A lot of the services are the same as hospice, but again, with hospice now being confined or restrained by the Medicare stuff, where they're losing some of their emphasis on these psychosocial and emotional kinds of support. Doulas can do that without worrying about having to do the extra paperwork, and you're spending too much time and you don't have to code it and that sort of thing. I'll just mention, if you are would ever consider medical aid in dying or VSED, I particularly would recommend end-of-life doula in those situations. End-of-life doulas, they cover the gamut in what they can provide, what they care about. I particularly like vigiling, for instance. I like to be with someone when they're going through their final hours, and helping the family to understand, you know, no, this is normal. What you're seeing, it's not scary. The person's not in pain, even if you hear them gasping. You know, those sorts of things. That's where I kind of see it. Some doulas charge, some have a sliding scale. I'll tell you, with medical aid in dying, there are some organizations who work to help you find a volunteer end-of-life doula for the actual ingestion day, which, you know, will take some of the financial bearing, maybe some of the psychological issues away from family and friends. And I guess just in closing, and at least this part of the conversation, to sum up, you know, I want to return to what I started with, the agency and the self-determination and priorities. So, you know, it's your life, it's your death. You know, it should be your priorities for all of it. And you know, approaching end of life, whether our own or loved ones, you know, sure, it can be time intensive and it's scary, can be challenging, but the support can be out there. You may have to push for it. You may have to advocate more for yourself or your loved one. So again, as I warned you at the beginning, I'm going to say it at the end. I encourage you to talk about these issues and to plan accordingly. And I do have, for what it's worth, I do have some resources here that for some of the topics we talked about, and there's my email address. I'm willing to talk to anybody about these kind of issues that may be interested. But With that, I'll go ahead and stop sharing my screen, and let's see how I get this back. Turn it back to you, Alex.
Thom, thank you very much for that presentation that covered so much ground in terms of some of the issues that people should consider at the end of their life, and some of the tools that can be used to make sure that the wishes that you have are respected near the end. Thank you very much.
Sure, thank you.
We did receive one question over the chat. I encourage people to, if you have a question, just raise your hand or jump in. You can also enter it in the chat if you're more comfortable doing that. And we'll have a conversation about some of the issues that that Thom went over. So the question was Andrew's, and it was, how is a pulse different from an advanced healthcare directive?
Well, I'd say they're both legal documents, but the pulse is signed by a physician, and it's very specific in what it details. An advanced directive for healthcare can be much more comprehensive. A pulse, for instance, asks if you, the first question basically is, do you want CPR? If you say yes, you want CPR, then that implies to them that you also want some other things. So you can't say I want CPR, but I only want comfort-focused treatment, for instance. But you can say I don't want CPR. Then you can opt for full treatment, selective treatment, and it's more of a document, a form. Whereas with an advanced healthcare directive, it covers the same kind of issues, but you can actually add more to it. And that points out. I really appreciate the question, because I didn't make this clear earlier. I don't think I mentioned it, that with an advanced care directive, you can also do a dementia addendum to it. So you can spell out, not that the again, with the dementia directive, you might still have some issues with people wanting to follow it, but you can specify to the level of, if I'm at stage 1 dementia, which means these kinds of things, I still want full treatment. I want this. And if I'm at stage 2, where perhaps I'm not able to recognize people and blah, 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 then I only want comfort care. And at stage 3, when I can't do these daily things of living and all that stuff, I would prefer that all food and nourishment stop. So you can get very specific in your advanced directives, particularly that one's for dementia. But even in general, with the advanced directive for healthcare, you're actually naming an agent, or you can name an agent, and I encourage everybody to do so. That's the person who would advocate for you on your behalf, so that your wishes get followed. Because you may say in your advanced directive that I don't want this, or I do want this. And some hospital people, even though they should be following it, they may balk. If you have a strong healthcare agent, or if you can't make decisions, say you didn't cover a particular thing. Remember where I gave the example where the physicians thought these people at the end of life didn't have the capacity to make the decisions, then, and they felt that the families weren't necessarily agreeing with them. If there's a healthcare directive that names an agent, that person has a legal responsibility and the legal right to act on your behalf. So I'd say the pulse is important if you have a serious illness. And again, the primary purpose of the pulse, though, would be for first responders who would respond to your home. And then that would dictate to them, this is what we're supposed to do. They would take the pulse and obviously turn it over to the facility that they take you to, if they take you somewhere. So it's a very important document. The advanced directive, I think, is a more comprehensive document, and can be a more comprehensive document. So I think a lot of people should have both. I think probably anybody 18 or over should have an advanced directive. I don't think it's ever too young to start thinking about the kinds of issues that you might face in an accident or something else. Whereas most people, unless you have a serious illness or potentially something that could impact your lifespan. Most people probably wouldn't need a pulse, but I think everybody should have an advanced directive, and there's no problem with having two. If you have two, I'd just make sure that they didn't disagree with each other. Like, don't say, yeah, I want intubated on this one and I don't want intubated on that one. You know, that would just make sure they're consistent.
Tom, just a follow-up question on that. Is a doctor involved in creating the advanced healthcare directive where the agent is assigned?
I don't think, no, that's not a physician's order.
Okay.
That's you stating your issues. And again, that's where the issue will come in. Is it the legal document? It's legal if the things that it's asking for are legal. That's why I think for the dementia directive, which that wouldn't necessarily be legally enforceable in some places. So again, it's kind of like tossing balls in the air and catching them. If you have early stage dementia and you think you may have to be hospitalized at some point, part of your vetting of the different facilities would be, who are the ones who would support me in this effort, you know, and if they wouldn't, then maybe I'll go somewhere else. Part of it is, again, is talking to your doctors now. How supportive would you be if something like this happened to me? Would you support me if I wanted to do VSIC? Would you support me if I wanted to do medical aid in dying? You know, and part of that is changing the narrative, you know, because again, a lot of doctors, it's not that they're not supportive, it's just they're not trained in it. And they don't necessarily see the financial benefit in doing it, you know. So it's as the more we talk about these issues, I mentioned this to Alex the other day. I was at this vendor show and there was somebody from a hospice there. So he was telling me how great his hospice was, and I said, oh, I have a question. Do you participate or support medical aid in dying? And he said, that's the #1 question we're getting. But he said, unfortunately, we don't. But the more we talk about it, the more we ask healthcare facilities and stuff, the more perhaps we can help change that narrative. I did check, even though hospices and hospitals and the like are supposed to have their, as of January, supposed to have their end-of-life policies online. I can tell you, I went to Desert Care Network, which covers JFK, Desert Regional, and some hospital up in Yucca Valley, I think. And I searched, I couldn't find it. So I searched and it said, End of Life Options Act. I couldn't find it. It said no match is met. So, you know, don't hold your breath waiting for them to do what the law says they're supposed to do. Eisenhower did have a statement saying that they are exercising their legal option. I don't have the exact words, legal option not to participate in the California End of Life Options Act. Okay, so that means, you know, you can't have it done in the facilities. There's some question. I have heard anecdotally that they don't allow their doctors, even the ones they contract with, to do it. Although I have also heard that they don't prohibit the doctors who work there from doing it on their own. So I really don't know about that. But again, finding a participant or a doctor is kind of problematic. There are agencies, if anybody's interested or needs one, I think I have some of them listed in the references I have it, who will help you find somebody. One of them in particular just came into being 2 years ago. They've helped 400 help across the United States where it's legal. They've helped 400 people find participating physicians. So far, they've been able to help every person that's asked. So there is hope out there. It's just you may run into issues and need support finding that help.
Yeah. Yeah, it seems pretty egregious that there's not more support from the medical systems here in the Valley for medical aid in dying, and especially.
And it's not just here in the Valley, unfortunately. And I know there's groups in Hemlock Society in San Diego. They're contacting every hospice in San Diego County, and pushing them. Why isn't it on your website? So there are these advocacy groups that are out there, trying to get answers to the questions people have.
All right, well, we need someone to start making a list here for Coachella Valley. I see 2 hands. We also have some questions in the chat. So let's just go to the hands. Casey, do you want to go first? And then I think it was Paul. Did you have your hand up? Oh, no, it was Jai. So we'll do Jai next.
Are there any implications with payouts on life insurance policies when medical aid or when MAID is selected?
No, it does not in fact impact your life insurance anywhere where it's legal in the United States.
Thank you.
Jai?
When I went to a physician trying to get more information on how to fill out the advanced directive form, what kinds of things I might want to specify in that document. My experience was, it was like I went to the wrong person to ask the question. He wasn't really interested in discussing that type of issue with me.
Mm-hmm.
And throughout your presentation today, which I thank you very much, you made reference quite a number of times about talk to your doctor about these things. And maybe if my condition were more advanced, it would be a different situation. But my experience so far is it's not something we're going to spend our time on.
Yeah, and unfortunately, and again, that comes, I don't want to keep harping on it, but that's how they are trained. That's how most medical schools train, to try to cure, try to resolve health issues, not to address crime. That's why so many referrals to hospice are in the last couple of days. It's because it's almost, I can't speak to their mindset, but it's almost like admitting defeat, and I think part of it is that changing the narrative, keep asking questions. I don't want to say change doctors because, I can't tell you to do that, but it's an important thing, when you're first starting with a new physician, what's your philosophy on this? I'm hoping that as physicians age out and the younger generation who's maybe more in tune with this kind of thinking, I'm hoping that's changing. I'm hoping that medical schools start offering more in death and dying. I think that's probably the case. They're offering it, but they're probably offering it more as an elective than a mandatory kind of thing. But here again, it's, get the form, download the form, look at it, think about it, talk about it with your friends, and figure out what is it that you think you want. Try again with your physician or a different physician, because if you feel you definitely, anybody on the call, anybody over 18, again, I'll say I think should have an advanced directive for healthcare, naming somebody who's going to advocate for what you want. But the pulse, I think anybody with, as I said, anybody with a life enhanced or life threatening kind of implications should have a pulse. And if your physician isn't supportive, I'd get the pulse and I'd fill it out to the best of your ability, and then take it in and say, I'd like you to sign this. It's, again, it's your life, it's your priorities, and that's you have the right to do that, and a physician should not stand in your way. That's my soapbox.
So if the situation that Jai described and that you also commented on is that you're not really going to get support or help from your physician, it is going to be a situation where you consult and have conversations with other parties and other resources, and then you just need to hand it to your doctor and say, this is what my wishes are. You need to put this in my medical record, et cetera, et cetera. Do you have listed some resources in your resource list of places where people can get ideas on what should be included in an advanced directive? What kind of medical conditions?
I think I included the advanced directive form. It's an online thing. You can actually fill it out online if you want and then print it. And these things are all over the internet. I tried to pick ones that I thought were reputable and aren't going to, sell your email address or anything. I think they're government sites. I didn't put the website for the Pulse, but I put information on the Pulse, I think, but I don't think I put the website. But if you type in Pulse in California, because they're Pulse, some places it's called MOST, which is a medical order instead of physician's order. But here, or locally, it's called the Pulse. And in other jurisdictions, it's on bright green paper. Here, it's bright pink paper. But if you just type that in and say Pulse in California, you can find a place where you can actually download, you know, a blank of this. And, you know, it's pretty easy to read. But again, if your physician won't talk to you, you know, I don't know if your health insurance covers, you know, social work or, you know, it depends on how strongly you want to argue against the physician, or just do it yourself and say, I want you to do this. Or, you know, if you're in a position where you're changing physicians, you know, look for somebody who is supportive and talks to you about this, because, you know, death and dying, as I said, it's looked at as a medical event, and that's why a lot of physicians don't want to go there, you know. Whereas if we looked at the whole issue of death and dying is, hey, this is the emotional side that I'm dealing with, the spiritual side of it, you know, it's the whole gamut. I know you're only interested in the medical side. I'm looking at myself as holistically, and I care about all of it, and that's why I want you to sign this form.
Yeah.
You know, it's a shame if you have to go that route, but, you know, I know and the same with not only with these directives, but when I mentioned about, you know, possibly looking at the treatment options and saying, I want to postpone this, or I want to delay this, you're going to run into resistance, because that's not how they're trained. It's not the mindset. I mean, not all of them. Obviously, there are some who are supportive, just like there's some who, you know, who are supportive of medical aid dying, and other ones aren't. So,
yeah.
You know,
Tom, I just want to point out that Andy posted a link to pulsed.org, which has a national Pulsed form. I would suggest definitely comparing that to a form. If there is a California specific form, it may be better to use that, just because of some of the issues we're discussing. You know, I think these documents have to be buttoned up. Because of the resistance that Thom is talking about.
The forms are probably very, very similar, I would suspect. And maybe on that site, you might even be able to link specifically to a California one. But the information would probably be pretty similar, I would think, at least to get you thinking about what you should include and that sort of thing.
Gary had a question in the chat. How are we assured that our doula will be immediately available when needed?
Well, that would be an issue that you would discuss before you select a doula, either for hire or whatever. You know, how much coverage is there? What are your cases? You know, there aren't a whole lot of end-of-life doulas in the Valley. Very few that I'm aware of, anyway. And it's something that you would discuss along with their experience level, what are their interests, how does that jive with your interests? Because again, it has to be a fit for you. It has to be something that fits your priorities. And just because somebody is a doula doesn't mean that they are the right fit for you. And they may say, geez, you know, I can't provide what you're wanting. Like I said, some doulas think their role in life is to do advanced direct or help do advanced directives and stuff. Mine's not that. Mine is trying to help point people in the direction of do an advanced directive. Here's where you can get some ideas of how to do it. But mine isn't. My thing is more, like I said, vigiling and the end of life. So it would have to be something that you would discuss before you engage professionally or even on a volunteer level with the doula.
Okay, thank you. Danny had a question. I think he means, can the Pulse be entered into an electronic health record in case of emergency or not finding the healthcare proxy?
I think it probably can be. I don't know, but it's a legal document. I would make sure your physician had one. If you're, you know, if you are in insurance kind of thing, like Kaiser or something, I would make sure their advocacy had a copy of it. There is, I don't know if you remember the slide that had the little bracelet for DNR, and I had the picture of the bracelet on one side and the picture of the pulse on the other. You can also, in California, well, you can buy them at Walmart. I wouldn't, not picking on Walmart, but I wouldn't just get a generic one. In California, you can get an actual post bracelet too, like you can get a DNR bracelet, and or a medallion that you could wear around your neck, for instance, and it would actually be a pulse that would serve as your legal kind of document, so that you're there even if you got in a car wreck. You know, you could, you know, they could access the information. I'm not exactly sure how, but it's on there, and they would know what treatment you did or didn't want in that way. So I think it should be absolutely able to be entered into your medical records. I know that advanced directives, I know every time I go to the doctor or anything like that, they say, do you have an advanced directive? And I say, yeah, you should have it on file. But I know that, you know, I go to Desert Oasis or whatever down on El Cielo, and, you know, I'm going next week for my wellness exam, and I know they're going to say, do you have an advanced directive? I'm going to say, yeah, it should be in your system. Could you check and see if it's in the system, you know? So those go in there, and if you go to be admitted in the hospital, they'll ask you if you have an advanced directive. Thing is, they don't always say, can we have a copy? I think they're covering their bases because they're required by insurance and by Medicare and those kinds of things to say that, you know, they have to ask if you have an advanced directive. But advanced directives, most physicians shouldn't argue with you about an advanced directive. They should want you to do it because I suspect they probably have Medicare, or, and I'm not being facetious when I say this, there's probably a Medicare code or an insurance code that they can put down and they get reimbursed for checking to see if you have an advanced directive. Not whether or not they have a copy. I would make sure they had a copy. But, and I would think the pulse should also be able to be entered without any kind of issue.
Okay, thank you. We have about 2 minutes left in today's session. Are there any other final questions or comments on what we learned today?
If I could just put a plug in for PAL's Death
please
Cafe, if you don't mind. PAL's has a Death Cafe. It's by Zoom, first Thursday of every month for an hour, 2 to 3 on the first Thursday of every month. Death Cafes, you don't have to have any experience or any, all it is an informal discussion of whatever's on people's minds about death and dying. So anytime you're interested, you know, feel free to sign up, and be a pleasure to see you there. And I want to thank everybody for today. This has been great. I appreciate the opportunity.
Thank you.
Awesome. Thank you very much, Tom. I'm glad we could have this discussion, and I think as we post it to our YouTube channel and to the newsletter and the website, it will provoke thought among others and keep the conversation going. Before we leave, I just want to remind everyone that the Let's Kick Ass potluck, monthly potluck, is tomorrow at 5 o'clock. I can't remember the address, but if you need, if you don't have that information via email, send me a chat or grab me before the meeting closes, and I can get that information for you. And then also coming up in September, we have the Positively Aging Conference, which is an annual half-day conference about HIV and aging from all dimensions, psychosocial, medical, and others. Christopher, do you want to add to that?
Just that it's the 6th edition of this. Our name has changed a little bit to Positively Aging Project. If I can get that out. Well, but it's going to have the same thrust and focus, and they've always been really dynamic. We're going to be doing it in person at Jocelyn Center, and hybrid also. It'll be broadcast. So we've got many new friends across the country, even across the world, that do participate in these events. So it'll be available that way. And it will be in the newsletter for Let's Kick Ass. It will also be on the HARP website. And if you're on the mailing list for the Positive Living series, that Positive Life series that Jeff Taylor produces, that you will get that notice also. But it's always a really great event. It'll be fun to be in person. And we have a good lineup this year. Thank you.
All right, thank you. All right, well, everybody enjoy the rest of their Saturday. And thank you for joining. And maybe we'll see some of you on Tuesday at the regular roundtable meeting.